This is Dr. Osen. She is specialty in neurology. She did her fellowship in Rush University Medical Center. She did her residency in neurology at Rush University Medical Center Neurology Department. She did her internship at internal medicine, Rush University Medical Center, internal medicine, and she did medical in Indiana University of Medicine. She is board certified for neurology, and her affiliations are with Advocate Christ Medical Center and Advocate South Suburban Hospital. Thank you, Dr. Rosen, for coming in and educating us on the topic.
All right, thank you so much. Very personal talk tonight. But yeah, thank you so much. So like you heard, I'm a neurologist, but I also did a couple extra years training in what's called neuroimmunology. So autoimmune diseases of the central nervous system, and MS, or multiple sclerosis, being the most common of those diseases. So gonna cover some of the basics, but also the exciting advancements, because this area of medicine and neurology has boomed quite a bit. Hello, welcome. Okay, so first we'll kind of start out with what is MS. And I think to get a good understanding of MS, we kind of have to understand the central nervous system itself. And so everything comes down to the neuron. So for instance, if my brain wants to tell my arm to move, it actually starts in this cell that's within the brain called the neuron. It starts in the cell body where my arrow is pointing. In order for that signal to go from the brain to the arm, it has to talk to a different neuron. And the way it does that is that the signal starts in this big cell body, but it travels down this long axon. And the axon is this kind of tail that talks to the next neuron. The chemical, or the part of the neuron that's important to keep an eye on as far as MS, is what's called the myelin sheath. So this is a fatty substance. It actually wraps around the axon, and it works as kind of an insulation like you would see in a wire. It helps the nerve signal travel faster and more efficiently down to the next neuron. And that's really important because you can see that the axon, so again, the neurons are out here, out in this kind of upper part of the brain called the cortex. And the axons have to travel quite far to get down to the next neuron and out to the next neuron and eventually to the place where it's going. So that myelin that really helps the nerve signal travel well and fast is really important. Now, what happens in MS to mess up the myelin? So this is an autoimmune disease, meaning the immune system, instead of attacking viruses and bacteria, gets confused and starts to attack our own tissues. And that's because sometimes the viruses, bacteria, look a lot like some of our own tissues, like myelin. And so the immune cells out in what's called the periphery, or the blood, so the B cells, the T cells you might have heard of, they become activated and they talk to each other and they say, we're going to go after this target. And unfortunately, this target looks a lot like myelin. That's a part of the axon that we just talked about. And so they activate each other and they cross what's called this blood-brain barrier. This is like the gate in between the blood and the central nervous system where our brain and our spinal cord sit. So these activated T cells, B cells are out to attack their target. And unfortunately, their target looks a lot like myelin. And so what happens is that they cause damage and kind of eat away at this myelin layer. And they just cause generalized inflammation too. And so when we have damage to the myelin, you can see this axon on the left. The signal is a smooth signal because the myelin, again, is helping it travel better. But when the myelin's kind of eaten up and ratty on the right side, you can see the signals can get disrupted, slowed down, or even lost in some cases. And that is what causes the symptoms of MS that we'll talk about here. Over time, the body can repair the myelin. It sends in these cells that kind of rewrap the myelin with that fatty tissue. And so that's why some of the symptoms will remit or go away. But it tends to always leave a scar behind. And that's where multiple sclerosis being a scar, that's where the name comes from. So we can see on MRI here, so we have a healthy brain here, just to kind of orient you, this is like someone being cut in half almost, so their nose is over here. You can see the brain is nice and gray. But over here with MS, there's these white plaques. So these are the scars that MS leaves behind. They can be in the spinal cord too. This is the gray part is the spinal cord. This is the vertebra, or the spine itself, but you can see this white scar-like material within the spinal cord. So what are some common symptoms of MS? So MS affects the brain, the spinal cord, the optic nerves, so it can cause a very wide range of symptoms for that reason. So some of the more common ones are things like vision loss, paralysis or weakness of the arms or legs, sensory changes, either numbness, lack of sensation, sometimes neuropathic pain. Some patients have difficulty with gait, and that's either due to weakness, imbalance, bladder symptoms, so difficulty controlling the bladder, memory, cognitive symptoms, and fatigue is fairly common too. Typically in MS, it occurs, and we'll talk about the different types of MS, but most common MS occurs in attacks or relapses, meaning that the symptoms come on fairly slowly, what we would call a subacute presentation, meaning that over hours to days, the symptoms progress and get worse. So for instance, a lot of patients will have numbness in the feet, slowly kind of creeps up to their waist, and then it'll stop for a little bit. And then over time, you have remissions where, again, that myelin's being repaired, and then those symptoms improve or resolve sometimes too. So how do we diagnose MS? Based on patient's symptoms, so we take a very thorough history. It's very important to get what symptoms they have, the timing of them. Our neurologic exam can give us some clues too. Is there weakness, numbness on the exam, certain other findings? MRI is our best tool, at least these days, at looking for those lesions or scars that we showed before. Lumbar puncture can be used, so that's also known as a spinal tap, where they insert a needle into the lumbar region to collect the fluid around the spinal cord to see if there's inflammation. Kind of the word that patients will often hear is what's called oligoclonal bands, or another sign of inflammation. Thankfully, with MRI, we don't need this as much because obviously it's not the most fun test to go through, but sometimes it is necessary. Here are some more MRIs. So again, the MRI is probably the most helpful diagnostic tool that we have as of today. And so again, you kind of see these white lesions. This black thing right here is called the ventricle. We all have that. MS really likes to hang around the ventricles. This one in the middle, so this is where we give patients contrast through the IV. And if it lights up with contrast, we know that it's on the newer side within the last 3 months. So that can kind of help. If it's lighting up here, it's new. These ones say they're not lighting up, that would be an older lesion. And then again, they can occur in the spinal cord as well. So to officially have diagnosed, or to have the diagnosis of MS, you have to fulfill what's called the 2017 McDonald criteria. This is a criteria that's been around. The most updated version is 2017. I think we're due for an update here soon. But essentially, you have to fulfill what's called dissemination in time and dissemination in space. So dissemination in time just means you need 2 separate attacks. So you can have 2 different relapses. Say someone loses vision and then it comes back. And then a year later, they have weakness, comes back. So that would fulfill dissemination in time. You also need dissemination in space. So 2 different areas of the central nervous system have to be attacked. And so that's a brain lesion, and there's 3 different areas of the brain that we count, and then spinal cord lesions as well. And so with all of these, we can kind of put it together if someone fulfills these criteria. There's a little bit, the optic nerve, so like we said, patients can get vision loss because of optic neuritis or inflammation of the optic nerve. It's currently not within the dissemination in space, but word on the street is it's going to be included in the next McDonald criteria. So what if a patient doesn't fulfill these criterias, but they're having attacks like MS, their MRI looks like MS? Then they would be classified more as clinically isolated syndrome or CIS. So you have one attack, not quite fulfilling the differences in space and time. Or some people get put into a radiologically isolated syndrome. So this is where someone gets an MRI for a different reason, say like headaches, and then they happen to find some lesions of MS. The good thing is that we still offer treatment to both of these patient groups, especially CIS, because as we'll talk later, it's important to start treatment as soon as possible. So who gets MS? Really anybody can. About 1 million people in the US carry this diagnosis, and the incidence or the number of people is growing, mostly because of MRI. We're just better at diagnosing it. And the criteria has been more inclusive, again, because we want to offer treatment as soon as possible. So classically, this is a disease in the younger age patient, so 20 to 50 is when they typically get diagnosed. Not uncommon to see someone a little older get this disease, and there are pediatric cases as well. It is more common in women, much like autoimmune diseases, which has to do with hormonal things and just us having the ability to get pregnant. And this used to be thought as a disease in young white women, really thought to be less likely in Black and Hispanic patients, but we do know now that it is actually more common in Black and Hispanic patients within the US. It's recently a big study that was released that showed that this was the case. Okay, I'm gonna skip this for now. So what are some risk factors for developing MS? One is low vitamin D, and that is because vitamin D actually keeps the immune system in check. And so how it does that is make sure that while the immune system has its gas where it's going and attacking viruses and bacteria, it's the vitamin D is part of the very complicated picture that keeps the brake on the immune system so it doesn't get too overactive like it does in MS. Unfortunately, we live in Chicago, so we all have low vitamin D because we get most of our vitamin D from the sun. So this is a fairly common risk factor, especially where we live. The second one is the mononucleosis or Epstein-Barr or EBV. So this virus is typically a virus that adolescents get, the kissing virus, I guess you would call it. But this has been heavily linked to MS. This is a virus that infects the B cells. And like we mentioned, those are some of the cells that kind of start the MS process. Those that have symptomatic mono are actually also at a higher risk of developing MS as well. There is some genetic risk within MS, but not a whole lot. So if a parent has MS, the chances of their child having MS only increase by 1%. So that's pretty low. If you have two parents, your chances go up to 10 to 20%. If you have an identical twin, someone that shares the same exact genetic material as you, it only goes up about 30 to 40%. So there really is an environmental factor too to this disease. Other risks are a little bit on the milder side, but that would be smoking because it causes inflammation in the lung, can spill over into the blood and then into the central nervous system, and obesity, typically more so childhood obesity. Okay, so there are different types of MS. The most common, we kind of talked about this, relapsing remitting MS. So if you look at the graph here on the right, we have disability on the y-axis, time on the x. And so you can see with relapsing remitting MS, you get these relapses. So you'll have symptoms, weakness, sensory changes, and then it gets better, it remits, and so on and so forth over time. Classically, we also have these progressive types of MS. So these are more of the slow progression. So you don't have those big bouts of weeks or months of symptoms followed by remissions. But over a time, like over a year's time, you notice my walking's not as good as it used to be. My memory's not as good without those big relapses. So that's where the progressive MS comes. And there's two different types. So there's primary progressive, where you kind of just start out having progressive symptoms without the relapses. There's also secondary. So these patients start off having the relapsing remitting type. And then over time, they start to have this slow progression, even without the relapses. And classically, these are always thought of two very separate entities, either a relapse or remitting or progressive. However, we have recently found that we probably have a little bit of both going on in most patients, not all, but most. And so this is kind of the newer outlook of relapsing remitting MS, where again, we have increasing disability on the y-axis and time on the x. So each relapse you do improve, but you are left with a little bit of disability. And over time, each relapse puts you at a higher risk of accruing disability over time. Okay, I'm gonna get a swig of water real quick, excuse me. So this brings me to the treatment of MS. All of these treatments are to prevent new lesions, new relapses, and disease progression. They don't really address any symptoms that are left over, unfortunately. But in this field of MS, the amount of drugs have really boomed, particularly in the last 10 years. So we can see the first MS medication developed was beta-seron in 1993. And up to even 2009, we had a handful of MS drugs. However, now we have over 20, and they come in a lot of different flavors. It's infusions, there's injections, there's oral pills as well. They work in a lot of different areas within the body as how they stop MS. They can work in the blood or the periphery, like we mentioned. They can work on that blood-brain barrier, as well as the CNS compartment as well. And there's many different targets of different types of immune cells too. So T cells, B cells, some are kind of a larger shotgun, if you will, approach that affect many different cells. And since there's so many of them, it can be a little overwhelming, especially when counseling patients. So we tend to divide them into 3 different categories. So the first category is this low effective medication. To give you an idea, these medications reduce relapses and new lesions by 30%. They're kind of the older school ones, the ones from the 90s and early 2000s. They are Rebif, Copaxone, Avonex, Aubagio. Most of them are injection medications. There are also moderate effective medications as the next level, and these reduce relapses by 50 to 60%. Some of those you might have heard of, like Tecfidera, Gilenya, Mavenclad. All of these medications are oral pills. And then you have the higher effective therapy. These reduce relapses by about 80 to 90% in the clinical trials, but I can tell you from real life, it's closer to 100%, to the point that if a patient has a relapse or new lesion on these medications, our first question is this MS? Because it's just very unlikely, to be honest. These are pretty good medications. So how do we pick, since we have so many options? It's a good problem to have, but this is how we look at it. So our goal is to prevent new relapses, new lesions, because we saw that each relapse or new lesions puts a patient at more and more disability. Even if they might improve quite a bit, if we follow them over time and allow them to have relapses, they're more at risk for disability further down the line. So we discuss the option based on the risk of each patient's disease severity and based on different characteristics, how many lesions they have. Are they getting better from each relapse? We can decide how aggressive we need to be with our medication. And then, of course, we always talk about side effects, make sure the patient and ourselves are comfortable with the potential side effects. And then it's nice that we have different options as far as, do you want to take a daily medication? Are you more interested in a monthly injection or a twice-a-year infusion? So it really gives us a lot of room to kind of really individualize each patient for what treatment's best for them, which is a very exciting part of MS. And the good news is that these medications are not lifelong. So MS naturally, and this was known even before we had medication for MS, it burns out around the age of 55 to 60 because our immune system's just not as strong and aggressive as it once was. And it eventually kind of retrains itself to not attack our own tissues over time. And so a lot of times when patients get to the age 50 or so, and that's different who you ask, but we will discuss stopping these MS medications. And so that's a long time if you're diagnosed in your 30s to get to 50 to be on a medication. But also there's a light at the end of the tunnel that we could get you off of medication if you would like to at some point as well. And like I said, treatment of MS has changed quite a bit, not just because we have more medications in our pocket, but we know that we just can't tolerate any lesions or relapses in order to give patients the best chance to avoid disability. So in the old days, I mean maybe like 6 or 7 years ago, we use more of what's called the escalation approach, meaning you would start with a lower effective therapy. If you were happen to break through, then we'd move you up to a moderate and high. But like we said, our goal is 100 or no relapses, no lesions. And so we actually start with some of the higher effective medications because again, they're almost 100% effective and they're well tolerated. They really don't come with as much baggage or about the same amount as baggage with side effects as the moderate. So it's kind of like, why not really give you a more effective medication in that case? MS, just a quick tidbit about MS and pregnancy. So for many years, historically, women with MS were told not to get pregnant. And that was because of fear that that pregnancy would make the disease worse. And that's really because after birth, the relapse risk actually increases quite a bit. But now with the medications we have enabled, and really controlling patients' MS, this is not an issue. That if any MS patient wants to get pregnant, they absolutely should. And we can kind of work things and really optimize the pregnancy experience as well as controlling their MS. We do almost always have to take patients off of MS medications during pregnancy to protect the fetus, but again, there's ways around this. And pregnancy itself, especially in the second and third trimesters, is actually protective against MS. It's really just that postpartum period that we worry about a little bit. But again, ways around it. Breastfeeding itself is also protective against MS activity. And so there's been great improvements made in MS and MS prognosis. This used to be seen as a very disabling disease for most people, but now it's really different. That's what's exciting to be MS. So before we had DMT, or I'm sorry, MS medications, about 50% of patients required a cane, typically around 15 years after diagnosis, which is a pretty big deal because if you're being diagnosed in your 30s, that puts you at 45. And so that's pretty life altering. However, more recent studies have shown that that's actually dropped to around 10%. And this is even before some of the higher effective therapies we have now. And the patients that do go on to need a cane, it's further down the line. Some studies say 17 years, some say 30. But overall, this trend is very promising. And again, I think it will continue to drop dramatically now that we have very effective therapy. So non-pharmacological treatments are also very important. So healthy diet, there's not a clear diet of which one works. They've tried everything, keto, paleo, but probably just a healthy diet that you can follow that doesn't drive you crazy is the best way to go. Exercise is really important as well. The old saying, if you don't use it, you lose it, is very true, especially in MS. We need to keep patients as healthy and active and moving as possible. Again, no clear guidelines on what is best. Aerobic versus weight training is probably a combination of both at this time. They're working on trying to find specific guidelines, so we're hoping those will come out soon. Smoking cessation, again, just reducing any inflammation within the body that we can is really important. Staying active cognitively and socially has also been shown to help MS, and vitamin D supplementation. Like we said, this vitamin helps regulate the immune system. And then one thing about progressive MS. So a lot of our medications don't address the progressive part. So again, that is kind of the slow decline in symptoms like walking and cognition and the absence of the relapses. However, there are new medications in the pipeline that we are excited about because this progressive pathology seems to be completely different from the relapses. And so there's new drugs that have a new target in the central nervous system that I believe are in phase 3. Things are looking promising. We're hearing through the grapevine. Hopefully they'll be out by fall is what they're saying, or the data will be out by fall. But that would be really exciting because that is kind of the missing piece in MS treatment as of now. But I will say, I do want to say one, last thing is that MS is incredibly treatable now and patients do really well. They have very little, if any, disability now because of these new drugs, and there's more and more drugs coming out every year. So I do want to say this, that I see a lot of patients, they're young, they're in their 30s, they've just been dealt this diagnosis, which is really tough to hear. And, patients in their 30s, they're starting to, plan their jobs, their careers, their families, and this kind of throws a wrench in that. And so I think it's very common for patients to go into a little bit of a denial when they first get diagnosed, very understandably so. But I would encourage that if anyone listening has MS, knows someone with MS, to, talk to a neurologist, talk to other people with MS. I'll have some resources for that. Because I really do in my heart believe that if we treat this disease at the beginning and effectively, that will give every patient the best chance to avoid any disability and live their life just like they were planning. So that's my one soapbox moment that I'll step down from. But here's some resources too for anyone that would like to learn more about MS or find just different groups and information. But the MS Society is probably the best resource that I would recommend. And then quick plug, there's some MS walks coming up. It's the walking season. Our group from Advocate will be at Orland Park. So if you want to come out and say, hey, they're pretty fun. But yeah, that's, I believe, all I have. When is it? The Orland Park, May 5th, Chicago is April 28th. There's many more locations you could find on the MS Society website. But yeah, that is kind of all I have. If people have any questions or, yes.
So with all these medications out here, how long have they been researched or?
Sure, yeah.
So
I'll go
how
back.
far, are you confident that there won't be long-term side effects?
That's a good question. So some of them have been out since the 1990s. Some of the newer ones that we have, so ocrelizumab here, came out in 2017, but it has a cousin drug called rituximab that's been out since at least the 90s. And so far it looks very safe to be on. And again, you're not going to be on it lifelong. You aren't for a long time. So that's a good question. But these seem to be safe as long as monitored appropriately, of course. Do you have a question with Tysabri? Yeah.
Yeah, that's natalizumab.
Yeah, that one's been on a long time. A lot of patients have, so this one, I didn't want to get in the weeds of the drugs as much, but Tysabri, basically it works by keeping out the bad T and B cells, right, out of the central nervous system. This one comes with the PML risk, or progressive multifocal leukocytopathy. And so that's where a virus that we all carry called the JC virus, or not, we don't all carry it, but most of us carry it, is a very weak virus that just kind of hangs out in the body. But patients on Tysabri, the virus can get into the brain and cause a fairly serious infection. And so patients that are JCV positive, we tend not to put on this drug, but that is a scary side effect for everybody when they're on that. But other than that, Tysabri is very safe and has been out almost 20 years now, which is kind of crazy. But yeah.
So if someone was interested in maybe, being in a research study
Yeah.
or something to that effect, how would they go about, would they talk to a neurologist and they can maybe refer them to?
Yeah, you can talk to a neurologist. Clinicaltrials.gov is always a good resource too. They tell you what, like, if you can put in what disease process you have, and they can tell you in your zip code, of course, and tell you what's close by.
Are there any studies being done at Advocate or?
Yeah, so some of those newer medications that address the progressive pathology are being done up in the Aurora and Park Ridge settings. We unfortunately did not have enough patients and I'm pretty new there, so didn't have a chance to really get off the ground. But yeah, that is kind of the goal at all of our advocate centers, to have clinical trials available.
Do you see that the cost of some of these medications coming down the longer they're out there?
Yes and no, unfortunately. So, like, for instance, the ones that came out in the 90s, you would think would go down. Those have actually gone up, or they're the same amount as some of the newer ones that I can't explain. There's competition. So yeah, the newer ones tend to go down every year while the older ones go up. Very hard to explain. I'm not in the pharmaceutical company. But I will say, at the end of the day, we get these medications covered either through insurance, or the pharmaceutical companies will cover them. So say what you will about them, they do cover the medications for patients. And so patients aren't being stuck with large bills. They get medications, which is nice.
So you mentioned that there's children that,
It's pretty rare, but yeah, it can happen in childhood, unfortunately.
Are there any type of infections that kind of trigger this off? Person I'm thinking of had shingles as a young adult, like around 20, that affected her optic nerve. And then some of these symptoms, from what I understand, came back like 10 years later, roughly. But then it was, other things along with it.
Yeah.
She got the diagnosis of MS. But would that, a certain type of virus possibly triggered?
That's a good question. So viruses can trigger autoimmune diseases just in general. In MS, it's the Epstein-Barr, the mono virus that we know for sure. So the herpes virus, or the shingles, they're all in the same family of the herpes. Has been studied, and to my knowledge hasn't been connected with MS, but at the same time, viruses tend to set off autoimmune or inflammatory reactions quite often. So it's possible. Yes. Yeah.
So MRI is the only way you can find out that if you have MS or not.
No, actually, so before MRI, it was based solely off of your symptoms, exam, and they would do the spinal tap in that case to show the inflammation. But MRI is a lot easier than, doing a spinal tap, and it's more specific too, because some things can look like MS in the brain, but it usually has a pretty distinctive pattern that we can look and we can follow over time to see if there's new lesions. So it has been helpful, but not necessary for the diagnosis of MS.
So if you have white matter, is it related to MS?
If you have white matter like findings,
Yes.
not always. It's usually in a specific pattern and has to be of a certain size, typically a certain shape.
Mhm.
A lot of people will just have white matter changes as we age, from blood pressure, headaches can cause them. We call those non-specific white matter lesions, and sometimes they get mistaken for MS, probably more than sometimes, to be honest. But a trained neurologist should be able to tell the difference between those like non-specific things not to worry about that we all get versus MS or inflammatory lesions. Good question.
How often does that happen, that somebody might be misdiagnosed? And it seems like they're with good reason to start these medications,
Yeah.
pretty soon. They don't delay that, but is there a chance, or maybe that the MS could just?
Yeah, so I'm probably biased because I see more MS or like the questionable cases get thrown my way more so than other neurologists, but it's not really uncommon. I can't really put a number on it, but I probably see at least one patient a month that was probably misdiagnosed. A lot of that probably happened before MRI was available, so the older patients are more likely to fall into that category. I'll say this, it never hurts to get a second opinion if you're concerned.
And could it be that by starting these medications right away, that they do such a good job that maybe they kind of like stop it, or is that?
Yeah, that's
is
the
that too
goal, right?
optimistic?
Yeah, that's the goal, right? Is that we start these and then nothing changes for the better. Hopefully, if anything, things get a little better. The lesions can go away. That's pretty rare, I'll be honest. They usually stick around. So if you have them, they stick around. But with these medications, that's like I said, we expect no more lesions is our goal.
So if somebody's functioning well with the lesions that they have on these medications, they can expect, as long as they stay on the medication, there's a good chance.
There's a good chance. Some people still go on to develop the progressive form. We're still figuring that out. Is it more of an inflammation part, or is it more of what we call neurodegeneration, or the genetically don't repair or hold up as well? So that we're still, I'll be honest, figuring out, but I can say, if MS is kind of we judge it in 5 years. You get to the 5 years, you're doing well. We expect you to get to the next 5 years doing well, and so on and so forth. But yeah, most patients, if we can prevent new lesions, they're gonna do well.
And if somebody's doing pretty well on them, it's like repeating an MRI, is that something that you could expect that you would do just to watch it? Or do you say if everything's going okay, we don't necessarily need to go and get more?
Yeah, it's a good question. Everyone's a little different. I think whoever you talk to in the MS world, most MS experts will do a yearly MRI of the brain, because the brain holds so much myelin that it can hide or cause asymptomatic lesions. If you've been stable for so long, a lot of doctors will kind of space them out, just because if you're on one of these high effective therapies, it is pretty rare to pick up new lesions.
And probably almost, okay, so if we find something, are we gonna do anything different? So,
Right, but and then for some, like for Tysabri you mentioned, we have to do an MRI to make sure about the PML and things like that. So we do MRIs for different reasons too, but you're right. At the end of the day, most of the time we can't escalate the therapy much further in most cases. But it's good to know that things are stable and nothing's changing.
so that virus would show up on
No.
Just
That's
if
a
it
blood test,
just if
right?
it caused PML. It's a blood test, so you're correct. Yeah.
so why would you do a yearly MRI on that if you're on that medication?
Just to make sure that the JC virus hasn't caused PML if someone happens to be JCV positive.
Yeah, it would be pretty clear to find an MRI.
It should show up on MRI, yeah.
And the PML again is,
Oh, it's an infection and it's infection of the brain caused by the JC virus. And it ironically causes destruction of the myelin as well, much like MS, but kind of in a more slowly progressive way.
and would you necessarily have symptoms with that?
You can have, you most likely would have symptoms. But again, sometimes depending on where it hits in the brain, it can take a little longer for those symptoms to come out.
What kind of symptoms would you have?
Yeah, so weakness, cognitive changes, vision changes, things that look like MS. So sometimes it can be a little hard to decipher what is what. So we get the MRI. An MRI, PML looks much different than MS on the MRI. So that's really helpful. Yeah.
And it's not real likely, or else they probably use that medication if they have other options.
If someone's JCV negative, it's almost a 0% chance. If someone's JCV positive, there's recent studies to get around that because some people really like this medication. Some people feel really good on this medication, like their fatigue and things are better. And if we give it every 6 weeks instead of 4 weeks, that lowers the PML risk even more, almost zero, not zero. But so there's ways around it. You just have to know how to monitor things.
Well, thank you. very
Yeah,
much.
thank you,
That's
guys.
A lot of information,
It
and
was, sorry.
very intricate information, but it sounds like very well received and
Yeah.
lots of good questions. So greatly appreciate it. I just want to make sure that everybody knows that there are more classes coming up here. There's a free skin cancer screening at the Evergreen Park Fire Department. And then Dr. Watson is going to be the next speaker here on Thursday, April 18th. And if you could all just drop this off at the desk before you leave, that'd be greatly appreciated. And thank you so
Yeah.
much, Dr. Osen.